Thank you for having me. Um, the presentations recently were great. Good job, Margie and Robert. I think um, we see a lot of the same challenges in ALD and trying to define early natural history and to understand how our early assessments dictate who goes to treatment and who doesn't. And then the difficulty in sort of doing all of this in a retrospective fashion. So I'm going to give a couple updates on ALD newborn screening and then how that relates to, in really the next 15 minutes, how that relates to some of the research work that's being done that parallels the work that's being done in Krabbe disease. These are my disclosures in terms of funding. So we'll talk a little bit about updated ALD newborn screening coverage, MRI surveillance guidelines, like I said, in parallel fashion to the work that Robert has done. Let me see, the chat popped up here. And a project that we're working on to look prospectively at the early natural history of adrenal leukodystrophy. So we'll start with ALD newborn screening coverage. And Joe, feel free to jump in here when it comes to the numbers. But I crunched these this morning based on census data from 2019. So based in 2019, 3.7 million babies are born in the US. At a conservative estimate of 1 in 17,000, we do the division, we can expect about 217 patients per year with ALD to be born. Dr. Orsini presented some data this morning that looks like, at least in New York, the incidence might be a little higher at 1 in 15,000, which would bump that number to about 240. And if you divide by 2, about half of them will be boys. So I want to show the map from 2017 of the patients, of the states that were rolling out newborn screening for adrenal leukodystrophy, and really draw your attention to the paucity of states that were newborn screening and starting testing. Those states in orange, that was back in 2017. Again, New York started in 2013. And have a look at the map now. It's quite impressive. And I'll just go back to draw attention one more time. All these gray states in the middle and blue states who were mobilizing 4 to 5 years ago, the majority have gotten up and running. And this is, and a large thank you to Lisa Seeger and her work that she's done with the ALD Alliance to get this up and running across the US. So the updated numbers as of 2021, I'm just going to draw your attention to the green states here. There's 23 states testing for ALD plus DC. If you look at the census data, that accounts for 2.4 million births out of the US per year. I added it by hand on my calculator this morning. And if you just sort of do the division, as of 2021, ALD newborn screening covers about 65% of all US births per year, which is really just, is absolutely incredible. So in terms of newborn screening, what do we do when we identify a patient with ALD? I'm going to give you an update on our MRI surveillance guidelines. And a special thank you to Hunter's Hope, who provided really an annual forum for a lot of people on this call and some players in the ALD world to come together and in a consensus-based fashion and in a data-based fashion, come up with the ALD newborn screening guidelines for MRI imaging. We performed a meta-analysis and then essentially asked everybody what we thought we needed to do in terms of frequency of MRI screening. So this was thankfully published online at the end of 2020 and then in January 2021 by the Journal for Inherited Metabolic Diseases. They were actually nice enough to put out a live abstract for us that really describes what we recommended patients be doing. I can just start at the top here. Boys identified by newborn screening for identified with ALD should undergo MRI surveillance for the conversion to cerebral ALD, which we see in about 30 to 40% of patients. So we performed a meta-analysis and went back, and out of over 1,100 cases, we found that the mean age of diagnosis was 7.9 years. If we were able to extract that data, the individual data, we can come up with a better point estimate. the median age of cerebral ALD diagnosis was 7, with an interquartile range of 25th to 75th percentile of 6 to 9.5. And if you sort of take the area under the curve, if you look at patients between 3 and 12 years, that's where 90% of the asymptomatic and early symptomatic cerebral ALD diagnoses were. And in similar fashion to Krabbe disease, but without sort of the time crunch early in life, once the patients develop cerebral disease on MRI, and we've confirmed that it is active on imaging, the recommendation is rapid referral to transplant. So given this distribution of disease, we came up with the surveillance guidelines listed here. Step 1, obtain your first MRI, baseline MRI, essentially between a year and a year and a half old. Obtain a second one a year after baseline. That gets you between 2 and 2.5. So you're getting a scan into your second year of life, second scan into your third year of life. And then beginning at 3, every 6 months, undergo a contrast enhanced MRI scan. Because if you look at the histogram on top there, that's where the highest incidence of disease is. Importantly, in reviewing the 1,100 cases, we did not identify a case of cerebral ALD from the literature from the past 30 years under the age of 1. So one of the major changes from one of the initial surveillance guidelines were patients should not or don't need to have an MRI between the ages of 0 and 1 years old. Imaging can start after the age of 1. And then a little bit of self-promotion here. The Journal for Inherited Metabolic Diseases actually was interested in doing a podcast with myself and Stefan Kemp, who's one of the ALD scientists out in the Netherlands, because multiple papers were submitted to that journal for that issue. So I talk about the surveillance guidelines and what the data mean, and Dr. Kemp talks about the evolution of ALD modeling systems for those who are interested. And in the last 5 minutes here, given what we know now about the establishment of newborn screening, the meta-analysis consensus guidelines that we came up with for imaging based on how we understand ALD to affect boys in the first, from a neurologic perspective, in the first 10 years of life, we're now trying to address the challenges that Dr. Kurtzberg and Dr. and Rob brought up a little while ago, namely how to fill in and understand how the clinical disease evolves over time and then when to intervene. So this is a prospective natural history project that's being funded through the GLIA RDCRN, of which I'm the lead investigator for this piece. And really, the overall aim of this project is to describe prospectively the early natural history of cerebral ALD, both in terms of endocrinological findings and cerebral findings. Because as we've just heard, sort of retrospectively going back and looking at data, while it can be informative, has a lot of you could be missing data, or you'll have a lot of incomplete data. So taking advantage of the infrastructure that's put forward by newborn screening, in very similar fashion to the previous project, we are creating a REDCap data form that has common data elements that anybody who takes care of somebody who has ALD identified by newborn screening can fill in. And those data points will get strung together over time from birth and give us prospective natural history data. So we started this project about 6 months ago. I'm working on the data elements and actually working on the coding. We have an initial version of our REDCap form, and I tested out the individual data elements to try to understand if we can string those together and get early natural history outputs, which we were able to do. So I'm going to show some data, but I'm not going to go into it because there are newer versions of it. But just as an example, we can create early natural history curves and understand how long it takes to treat the patients, how long it takes to treat the patients with really minimal stage disease. If you look in the bottom row there, can we separate out the patients based on imaging characteristics who had enhancement on their MRI at birth versus who had enhancement at a different time point, and understand when those things happen, and then how did that affect treatment? How did that delay treatment? So again, in similar fashion, I think across the leukodystrophies, there's high interest in understanding the early natural history of disease in order to optimize, as was earlier stated, our testing, and then again to optimize treatment. And so the next steps for this is multi-site data collection and harmonization. And then we're going to iterate this a bunch of times to hone in the data elements to make sure that it's widely usable across sites. So these are my acknowledgments. I have a lot of people to thank for a lot of the support that they've given me over time, and I'm happy to take questions.